So hello and welcome to this webinar on data analysis and query building with MedDRA. I'm Caroline Wilson and work as a medical officer at the MSSO, and I will be your instructor today. And I'm joined by my colleague Leander, who has been speaking to you before. We both will take you through this webinar that will take around 2 hours. So we have plenty of time for exercises, demonstrations, and for addressing your questions. And as Leander has already mentioned, please submit any questions you may have during this webinar through the question panel that you find in the control panel of the GoToWebinar application on the right hand of your screen. And I will allow as much time as possible for questions both during the course and also at the end of the presentation. Now let's start. Many of you will already be familiar with the content of this first slide. It's a standard slide that we have at the beginning of our webinars. The development of MedDRA was adopted by ICH in the mid of the 1990s. And ICH has also finally become the owner of the terminology. The MSSO was put in place by ICH to maintain, further develop, and distribute MedDRA on contract. And all MSSO activities are overseen by the ICH MedDRA Management Committee, with members from industry and regulators from the ICH regions, and a member from the WHO as an observer. This presentation is protected worldwide. Be aware of these disclaimers and copyright notices. So ICH is not only the owner of MedDRA, but also owns this training material. And you may use the slides with the exception of the ICH and MSSO logos, but will have to clearly indicate that ICH owns the copyright. Also, any adaptations of the slides have to be clearly labeled. The second bullet point refers to warranty and liability issues you should be aware of. And the third one is not relevant for today because we will not be using any third-party slides. Now, these are the topics that we will cover today. We will first look at the PTC document, Points to Consider document, for MedDRA data retrieval and presentation. Then we will address some important principles that should be considered when retrieving, presenting, and analyzing MedDRA-coded data. After that, we will look into how MedDRA can be used for developing queries and what a query actually is. And at the end of the session, we will conclude with a last Q&A round. In order to make our webinars as interactive as possible, we are using quiz questions in between. And this slide now explains about the polling. The easiest way to join the quizzes is to scan this QR code here with your cell phone or tablet, and it will bring you directly to the poll. But you can also enter the specified web address in the URL bar at the top of your internet browser on your computer, tablet, or cell phone. It's pollf.com. It will then take you to a log-on screen, and you'll be asked for a username. The poll is completely anonymous, so you don't need to enter your name, but please enter my name as the username, that is Carol N. Wills 584, with no spaces, and click join. And as soon as I activate the first question, you'll be able to see it and respond. I just leave this on screen for a moment so that you have time to enter the required information, but you don't have to get under time pressure because you will be able to see these credentials on each slide that relates to the quizzes. And as Leander has already mentioned, she has put these credentials in the chat as well. And should you lose the connection in between, just let us know. I can then show the QR code again so that you can reconnect. So let's see whether it works. It seems to work. Oh, we have all continents. Somebody's in the Antarctica. I think this is not correct. I see the colleague from the US there. We have Africa with us, Australia, the Philippines, India, many people from Europe, Asia, Turkey, I see, Italy, England. So Europe is quite crowded, not easy to identify the countries. So welcome everyone. Guten Morgen, buenos días, bon dia, and good to have you all with us. Nice to meet you all. So now let me introduce an ICH guidance document for our topic today that is called MedDRA Data Retrieval and Presentation. Points to consider. But before going into details, I would like to ask you the following. What do you think are the benefits of using MedDRA? What are the benefits using MedDRA? The fact that MedDRA was implemented by ICH and this has become the dictionary that is used for capturing safety data, both in clinical development as well in the post-marketing area. Unified coding, common language, uniformity, standardized terms for pharmacovigilance, uniformity, standardization. Exactly. Data categorization for easy analysis, common language, perfect. Standardized adverse effect terms is a must for clinical practice and research. Unification, pharmacovigilance, exactly. So the harmonization, standardization, this is really the benefit of using MedDRA. We are using the same standard, we are using the same language when we exchange safety information. Perfect, thank you. So we all agreed that the benefit of using MedDRA is the standardization, harmonization. And standardization is not only achieved with the terminology itself that allows us to speak with one language, you mentioned that, but also by an additional ICH document providing coding and data retrieval and presentation guidance. So here's a snapshot of the front cover of the full PTC document for MedDRA data retrieval and presentation. It is the latest version that was released in March this year, and it provides data retrieval and presentation options for industry or regulatory purposes. And it should, of course, be used in combination, in conjunction with the PTC document for MedDRA term selection, the coding guidance, because accurate and consistent coding is a crucial prerequisite for effective and efficient subsequent data retrieval. And finally, internal approaches and processes for data retrieval and analysis should not be in conflict with what is outlined in this document, the MedDRA data retrieval and presentation PTC document. The ICH points to consider guidance documents were developed and are maintained by an international expert working group appointed by the ICH Management Committee with members from regulators and industry of the ICH regions, Health Canada, the regulatory authorities of Korea, Brazil, and China, the MSSO, the MedDRA Maintenance Organization, and the Japanese Maintenance Organization, or JMO, and also the WHO as an observer. So this group does not only provide the guidance document for data retrieval and analysis of MedDRA-coded data, but also additional documents that provide guidance for operational coding. So the original and comprehensive, the complete version of the PTC document for MedDRA data retrieval and presentation is available in English, in Japanese, Chinese, Korean, Spanish, and Russian. These documents are updated with each major MedDRA version release. That means beginning of March each year. In addition, there are condensed versions, shorter versions of this original full document in all MedDRA languages except those where the full version is available. So these focus on the general data retrieval and presentation principles without going into further details for selected topics. They are not updated with each MedDRA release, but on an as-needed basis. And you can see the languages down here, where condensed versions are available for this document: Arabic, Brazilian Portuguese, Czech, Dutch, French, German, Hungarian, Italian, and Portuguese. You'll find these documents on the MedDRA website and the website of the Japanese maintenance organization. They are provided in several formats, like a navigable HTML format, in PDF or Word format, that would allow incorporation of text into SOPs or other internal documents. And in Word format, you'll find a so-called redlined version, which highlights the changes from the previous version. So it makes it easier to identify the changes as compared to the previous version. So with each release, you don't need to read the whole document again, because this redlined document makes the identification of changes quick and easy. So now let me show you how to find these documents on the MedDRA website. Let me switch screens. Here we are. Here we have the MedDRA website. And if you click on how to use, you see support documentation. If I click on this header here, a new window opens, and here we have the points to consider documents. If I click on it, you'll see the latest version of these documents listed here. So here is the MedDRA term selection points to consider document, the coding guidance. And here is the MedDRA data retrieval and presentation points to consider document in the different formats. And here the redlined versions. In addition, there is a MedDRA points to consider companion document. This is again a coding guidance. So we are focusing on this document today, the MedDRA data retrieval and presentation, PTC. Let me go back to the presentation. Here we are. And look into this document. The first section of the document covers some general principles, and you see them listed here. The impact of the quality of source data, the relevance of the documentation of data retrieval and presentation practices, the principle to not alter MedDRA, the impact of organization-specific data characteristics on data retrieval, also characteristics of MedDRA that impact data retrieval and analysis, and the impact of MedDRA versioning. All of this is addressed in this document. Then the document goes on looking at data queries, what they are, and the different methods for data retrieval and presentation, and what the impact would be of using one of these approaches. And finally, the document also addresses the SMQs, the standardized MedDRA queries, and the customized searches. We will discuss all these topics in our session today, with the exception of the SMQs that are addressed in a separate webinar that will be provided Tuesday next week. Now let's look at the general principles first. The quality of the source data is really key. So when receiving vague or ambiguous information, one should always seek clarification, because the quality of data output really strongly relies on the quality of data input. But of course, another prerequisite for high quality output is medically accurate and consistent MedDRA coding. Also, the method of legacy data conversion is crucial for the quality of future data retrieval output. There are two methods that can be used. The first is quick and straightforward. One just takes the previous legacy term and maps it to MedDRA. The terms from legacy terminologies like CoStart, HUART, ICD-9, and HARTS have been added to MedDRA at LLT level, so that taking this approach is a really easygoing exercise. But unfortunately, you may know, the legacy terminologies were much less granular than MedDRA, and some workarounds were needed to find somehow suitable terms. For example, there was no term for rhabdomyolysis in HUART. So if rhabdomyolysis was reported, the event could only be coded to myopathy, a much more general term. So when doing the legacy conversion with a mapping approach, such cases would still only be represented by the MedDRA term myopathy, although a much more specific MedDRA term for rhabdomyolysis is available. Now this illustrates that the second option for legacy data conversion, using the original verbatim, is much more suitable. It's much more valuable. So with this approach, you would take the verbatim and really code it to MedDRA. So no mapping approach, it's a recode based on the verbatims. Of course, you would always consider the previous legacy term, but the combination of this, the verbatim and the legacy term, would lead you to the most specific term that you can find. So this illustrates that this option, the legacy data conversion using the verbatims, is preferable. It takes more time, is more work, but will better support data retrieval long term. So it's like usual. Quality usually comes at a price. So if your legacy data conversion was done based on the legacy terms only, your retrieval approach must be much broader, considering more unspecific terms like myopathy in our example. If it was done by coding the original verbatim, your retrieval approach can be much more focused, much more narrow. Documentation of the data retrieval and presentation practices in your organization is essential so that everybody can understand what you are doing and the way how you have created the data output. This applies both to the usage of SMQs, the standardized MedDRA queries, as well as to the creation and the usage of customized queries and related processes. So it is all about transparency, both for your colleagues as well as for inspections, for instance. Any organization-specific guidance should, of course, be consistent with the ICH Points to Consider document. I mentioned this already. Retrieval and presentation practices must also consider the organization-specific coding conventions. If the in-house coding conventions, for example, avoid splitting of combination terms that include information of a specific infection, site, plus the infectious agent, and request to code to the infectious agent only, there will be no option to reliably retrieve, let's say, cases of respiratory infections by this specific infectious agent, because the affected site was not captured when coding. You will need quality assurance procedures, especially when creating and implementing homegrown queries. They will have to be tested before release into production and may also have to be adapted based on practical experience when using them. Consideration of versioning aspects is also crucial. First of all, the MedDRA version used in your retrieval must match the version that is used for coding of the data. But also, the general upversioning process of your data must be considered. It makes really a huge difference whether the upversioning process is limited to the replacement of new non-current terms, or whether the effort is taken to also replace previous coding by better terms that became available with the new MedDRA version. With the latter upversioning approach, the search can be much more focused. And when using the first versioning method, so replacing the non-current terms only, a much broader approach will be needed, because you would have to look for more general terms that were used in coding before a more specific term for a reported medical condition or finding became available. Did we receive any questions so far, Leander?
Thank you, Caroline. There's currently no questions, but thank you for asking.
Thank you. At the beginning, you have stated that the benefit of MedDRA is harmonization and standardization. And yes, the strength of MedDRA lies in the fact that it is a standardized terminology that has a predefined hierarchy. When an LLT is assigned during the coding process, the PT, HLT, HLGT, and the SOC allocation is already predetermined by MedDRA. And MedDRA users must not do any ad hoc alteration to it, even if your database allows to do so. Making such ad hoc changes would put at risk the integrity of the standard and is really strongly discouraged. If you do in fact come across a term that you find is incorrectly placed, then please follow the established change request process and submit a respective change request to the MSSO for consideration. Next principle. For running data retrievals, you should also be very aware of the structure and characteristics of the data you are looking at. Usually, the verbatim and the assigned LLT are stored in the databases. So when planning for data retrieval and data presentation using the HLT or HLGT level, higher levels in the hierarchy, some programming effort and work will have to be done in order to run such an analysis. We already talked about the impact of the chosen legacy data conversion on data retrieval. In addition, coding practices may change over time. The PTC document for MedDRA term selection, the guidance for operational MedDRA coding, is very stable. But some more specific internal conventions may change over time. As a principle, this should be avoided if possible and should only be considered when absolutely necessary for good medical reasons, because such changes will always lead to inconsistencies in your database, making data retrieval more complex and more tricky. The structure of the database may also have additional limitations and, for example, could not allow for secondary SOC analysis and the corresponding data presentation. Again, programming effort and work would be needed for doing so. And finally, data output will depend on the applied term selection principles, the coding conventions that you apply. Let's take the examples of the lumpers and splitters. That is how we call it, lumping and splitting information when coding. The ICH coding guidance provides two options for coding of a confirmed diagnosis with its characteristic signs and symptoms. The preferred one is to code the diagnosis only, so lump the reported information. But the second option also allows to split this information and code the diagnosis and all reported characteristic signs and symptoms separately. So splitting of these signs and symptoms and the related diagnosis will lead to increased event counts, of course, using the same SMQ, standardized MedDRA query or customized query. If diagnosis only is coded, the count would be much lower. So these are all items that need to be considered when talking about your organization-specific data characteristics. Another principle discussed in the PTC document is the impact of the MedDRA characteristics, namely the hierarchy of the terminology and its multi-axiality. So let's address the hierarchy first. When building queries, most users are looking at the system organ classes and the PTs under these system organ classes. But this does not take into account that MedDRA supports data retrieval and analysis via its hierarchy. There may be other levels in the hierarchy, like high-level group terms or HLTs and the high-level terms or HLTs, and that may be of benefit for a particular area of interest. So please consider these grouping level terms for your analysis, the HLTs and the HLGTs. And here we have the example in SOC cardiac disorders. We are looking at the HLGT cardiac arrhythmias and the HLTs underneath, where you would find most of the relevant PTs representing cardiac arrhythmias. So the HLT cardiac conduction disorders, the HLT rate and rhythm disorders, NEC, not elsewhere classified, the HLT supraventricular arrhythmias, and the HLT ventricular arrhythmias in cardiac arrest. These NEC groupings, you should always look into those. So these group terms that do not fit into any of the other HLTs, but still there may be PTs in there that are relevant for your specific question. So if you were interested in the occurrence of supraventricular arrhythmias, you would look at the HLT supraventricular arrhythmias and the HLT rate and rhythm disorders, NEC. Because some supraventricular arrhythmias may have been reported vaguely, so that's why you should look into this NEC grouping. But also remember the non-multi-axial SOCs, like for instance SOC investigations with some PTs related to relevant ECG findings. We come to this later. But this is how you can use these grouping terms in the hierarchy of MedDRA for your data retrieval and also for your data presentation. When using these grouping terms, be careful and make sure that you don't make one of two mistakes. Let's say in the first example, you were interested in the concept increased blood pressure in your data set. You could look into MedDRA and find an HLT named vascular test NEC, including blood pressure, and say, why not use all PTs under this HLT because it covers blood pressure measurements? But then you would not only retrieve blood pressure increased terms, but that you are interested in, but you would also include terms like blood pressure referring to blood pressure decreased. So using the full HLT for your search in this instance would produce a lot of irrelevant cases. Now let's look at another problem that you may have. Let's suppose that you are interested in finding cases of Stevens-Johnson syndrome in your database, typically described as a severe bullous condition of the skin that is often related to drug exposure. So you could search in SOC skin for bullous conditions and only look into the respective HLT, bullous conditions. Copy these terms and perform your search. But then you would be too restrictive and lose one relevant aspect, because often cases of Stevens-Johnson syndrome are not reported that way because Stevens-Johnson syndrome is a type of exfoliative dermatitis. And we see that this PT, dermatitis exfoliative, is grouped under a different HLT that is exfoliative conditions. So be careful when using grouping terms for your search not to make either one of these errors. In the first example, your search would be too broad and reveal a lot of irrelevant cases. And in the second example, you would be too narrow and you would have missed cases where Stevens-Johnson syndrome was reported as a serious exfoliative dermatitis. Another characteristic of MedDRA is its multi-axiality. Here see obesity cardiomyopathy as an example. It has SOC skin, it has SOC, oops, what do I have? I have the cardiac disorders here, sorry for that. We have the obesity cardiomyopathy, we have SOC cardiac disorders because it's a cardiomyopathy. That's why you have the manifestation site as primary SOC. And the HLT myocardial disorders and HLT cardiomyopathies. And then you see a secondary linkage that reflects the etiology of the condition because we are talking about obesity cardiomyopathy. So we have a secondary linkage to SOC metabolism and nutrition disorders. Here it is. And you see the hierarchy here. So obesity cardiomyopathy would be linked to general nutritional disorders, NEC, HLGT appetite and general nutritional disorders. And here is the highest level, the SOC level. So why is a primary SOC assignment needed at all? Again, in order to achieve standardization for cumulative data output of MedDRA-coded data, all PTs with multiple SOC linkages need to have a default or primary SOC assignment. And this assignment will determine which SOC represents the multi-axial PT during cumulative data output and presentation for integrated safety summaries, periodic safety reporting, etc. It prevents double counting of events of such PTs that are multi-axial. So a very nice feature of MedDRA. The primary SOC allocation defines how your data are distributed in the terminology and will appear in the standard tabulations on SOC level. And this will, of course, also impact the frequencies per SOC. As an example, many hepatic disorders will be represented in primary SOC hepatobiliary disorders. But other liver-related conditions are grouped under other SOCs, like, for instance, the PT coma hepatic is represented in primary SOC nervous system based on its manifestation site, or PT hepatic infection is represented in SOC infections and infestations. And in SOC surgical and medical procedures, you'll find other relevant terms like, for instance, liver transplant. Per convention, main data presentation in cumulative data outputs is per primary SOC. When people are looking at their safety data, they are mostly looking at the primary SOC allocation of PTs. But secondary SOC allocations of PTs can be used for alternative views at your data and for alternative ways to present the data. So often the etiology of the conditions is represented by secondary linkages, as we saw with our example with the obesity cardiomyopathy. And I will show you a related example later on. And just to let you know, more than 40% of all PTs in MedDRA are multi-axial, so have one or more secondary linkages. What is really important to know is that the PTs in 3 SOCs are never multi-axial. And these SOCs are SOC investigations, SOC surgical and medical procedures, and SOC social circumstances. And it is really crucial to remember this when building in-house queries, because none of the PTs in these 3 SOCs here can be found in any other system organ class by secondary linkages. You will always have to look into these system organ classes when building a query to find potentially suitable terms for your specific question. So you will not find any terms that relate to lab results of hepatic lab results, so hepatic parameters in SOC hepatobiliary, but you will only find them in SOC investigations. And you won't find terms for hepatic surgery in SOC hepatobiliary. Again, they are only represented in SOC surgical and medical procedures. And a term like hearing aid user, you'll only find in SOC social circumstances and not in SOC ear disorders. I stop here again. Leander, did we receive questions? Are there any questions so far?
No questions. Thanks, Caroline. Just when you do your next quiz question, can you show the QR code?
Yes,
we had a few people
trying
to join PoleLab. Thank you.
I will. Thank you. So here now a practical example for using grouping terms. We are looking at a number of PTs in the SOC investigations. Because SOC investigations is a non-multi-axial SOC, these PTs can only be found in this particular SOC. And I'm doing a comparison of my drug versus placebo. And my question is, does my drug relative to placebo have a problem, and if so, what kind of problem would it have? When looking at the PTs, you see that a number of lab tests and other investigational findings are represented, including aspartate aminotransferase increase, blood creatine, phosphokinase increased, blood glucose increased, lipase increased, white blood cell count decreased, amylase increased, etc., etc. And the list continues on the next slide. So blood pressure increased, occult blood positive, protein urine present. So let us now approach this differently, and instead of looking at PTs, we will look at grouping terms at a higher level of the MedDRA hierarchy. We are now looking at the same data, but on the HLT level, and the picture becomes much clearer. What we are now seeing is that there may be a problem in the area of liver function analysis, liver function tests related to my drug. It gives you an idea on where a safety issue may be, but of course this is not proof positive and it will need further case review and also medical assessment. But what this example shows is that looking at the PTs only may dilute a potential signal. So sometimes it's really very helpful to use higher levels of the hierarchy. So let me show the QR code again. Here it is. Please scan it to reconnect. And here's our question. If safety data are to be presented in tables or other formats, you choose the primary SOC based on product specifics, or you follow the predetermined MedDRA hierarchy. What would you do? Remember the principles that we just discussed. Based on what you just heard, how would you approach this poll question? See that many of you have already voted. Let's see what you are leaning to. Oh, We have a split of opinion here. So most of you have the correct answer, follow the predetermined MedDRA hierarchy. Let me close the poll. So this is what we discussed previously. Do not change MedDRA. You all agreed that MedDRA is about standardization, harmonization. So there is a standardized hierarchy in MedDRA, and users should not make any ad hoc changes to this hierarchy. So any primary or secondary SOC assignment. If you find that something is wrong based on your view, then submit a change request to the MSSO for consideration, but never perform any ad hoc changes in MedDRA. Let's now look at two PTs and think about their SOC linkages. Where would you expect to find allergic eczema? Based on manifestation site of the condition and its etiology. Allergic eczema. What would you do? So most of you, the majority, got it right. Based on its manifestation site, it's an eczema. The primary SOC is the SOC skin and subcutaneous tissue disorders. And based on the etiology of the condition, it's an allergic condition, we have a secondary linkage to immune system disorders. Most of you got it right. So primary SOC would be SOC skin, secondary immune system disorder. Manifestation, the site of manifestation is mostly the primary SOC assignment of terms with some exceptions. And the etiology is mostly represented by secondary linkages. Next one. In which SOC or SOCs would you expect to find PT cerebrovascular accident? Cerebrovascular accident. Manifestation site and etiology. So here we have the manifestation site of a cerebrovascular accident is, of course, the nervous system. So nervous system disorders would be the primary SOC. And a cerebrovascular accident is caused by hemorrhage, an embolism, or thrombosis, so a vascular event. And that's why the secondary linkage is to SOC vascular disorders. Some of you have voted for blood and lymphatic system disorders, yes, but it's the vascular component, the embolism, the thrombosis is captured with vascular disorders. So well done. And now, very important, please identify the non-multi-axial SOCs, because this will be very important to remember when you build your own queries. Exactly. Perfect. Investigations, social circumstances, and surgical and medical procedures. Product issues, they have secondary linkages. So it's really investigations, social circumstances, and surgical and medical procedures. These are the three SOCs where you always have to look into if you build your own query, because there are always relevant terms in there that need to be considered. So now we are still talking about the general principles addressed in the PTC document. In addition to MedDRA grouping terms and multi-axiality, versioning is a really important point that has to be considered. As we know, MedDRA is updated twice a year. So on 1st of March each year, we have the 0.0 release, the major release that affects all levels in the hierarchy, and on September 1st, the 0.1 release, the minor release that only affects the LLT and PT levels. Now, how will you know about the changes made? There are different resources. First, the What's New document that provides a general overview on MedDRA developments and summary tabulations of the changes made. Always recommended to read because it is short and it provides a nice summary of the background and rationale for instance, complex changes in the MedDRA hierarchy and systematic changes based on proactive change request. A version report is part of each new MedDRA version package, and it is a spreadsheet providing a summary table of the changes made and additional separate tabs for new LLTs, new PTs, PT demotions, LLT promotions, LLTs that changed the PT linkage, new PT linkages, primary SOC changes, etc., etc. So a very comprehensive report of all these changes. And in addition, all MedDRA license holders have the option to use the so-called MVAT, the MVAT tool, the MedDRA version analysis tool that I will introduce in the next few minutes. When documented your in-house queries, always include the MedDRA version that it is based on. Also, when presenting the data, document the version used. And when running the query, make sure that the terms in your query are coded in the same version as used in your database. If the query is to be reused in the future and your database has been upversioned, the query will have to be upversioned as well, meaning that the PTs used will have to be checked for changes, whether a PT was demoted, for instance, and the terminology will also have to be reviewed for potential new PTs of interest. So maintenance of these queries is quite complicated. There are many changes that need to be considered. Not only changes in MedDRA in the MedDRA hierarchy, but also new PTs that became available for your specific question. Here's an example for the impact of MedDRA versioning on data output. In version 22.1, your retrieval revealed 15 events of a fractured ischium and 5 events of pelvic fracture. Here you can see it. In MedDRA version 23.0 now, only 20 cases of pelvic fracture are retrieved because PT fractured ischium was demoted under PT pelvic fracture. There is no change in the type or number of events, but the data are presented in a different way based on MedDRA version changes. There may also be primary SOC changes that affect your data presentation. In this example, PT vascular cognitive impairment had a primary SOC linkage to SOC psychiatric disorders in version 22.1. Therefore, the relevant events, 20 of them, were presented in SOC psychiatric. But the primary SOC linkage changed in version 23.0, and the PT is now grouped in primary SOC nervous system disorders based on MedDRA naming conventions or MedDRA hierarchy conventions. Again, there is no change in the type or number of events, but the data are presented in a different way based on MedDRA version changes. Now let's look into the MVAT that can be used to check the extent and impact of MedDRA version changes. It is a web-based tool that is free to all users of MedDRA and that you can access using with your user ID and a password using this URL here. Now let me summarize its functionalities. So the first feature listed on the slide is the generation of version reports. in the same format as the usual version report that you get with the new version releases. But with MVAT, you can not only compare the new version with the previous version, but you can compare any two versions of MedDRA that you define. So, as an example, when a clinical trial is run over 5 years and you use the starting version throughout the clinical trial, you can compare this starting version with the newest MedDRA version in order to get an idea of what has changed in between and what the impact of upversioning on your data would be. The second feature of the tool is the identification of changes in a specific data set that you can upload into the tool that you have already coded. Up to 100,000 rows can be uploaded, meaning the LLTs or PTs and their corresponding numeric codes. The tool will then show you the changes to those LLTs or PTs between the version that was used to code the data and any MedDRA versions that you define. These may be changes in the hierarchy, or it could be that an LLT was made non-current, etc. But please be aware that MVAT has no autocoding feature, so you cannot upload your verbatims and expect that the tool will identify better terms for your verbatims that became available with the new MedDRA versions. So you just upload the MedDRA terms that you have assigned your two verbatims, and the identification of better terms that would be relevant for a query, for instance, would still have to be done manually. Please note that there are no confidentiality issues when loading your own data into the tool. The loaded data stay in your computer and are not stored after you close the MVAT session. And the third and last feature of the MVAT helps identify changes to a single individual MedDRA term or code. This can be useful to explore, for instance, the impact of versioning to a single term that represents an area of concern of a specific medicinal product. The user interface and the report output of MVAT is available in all MedDRA languages. MVAT also allows for addition of secondary SOC information in your retrieval output and comparison of the latest released version of MedDRA against the supplemental next version, so the current status of the next forthcoming MedDRA release. Time today will not allow for a demonstration of the tool, but you may want to refer to the MedDRA website under the headers Training and Training Materials and Tools, where you will find recorded webinars in which the features and possible uses of the tool are shown. And I will shortly show you where to find it. Again, the MedDRA website, and here we look into training materials, and tools. Here we are. And here we have the MedDRA browsers. Here's the demonstration of MVAT. We have a Chinese, English, and Korean version of this training. So you can easily access this via our MedDRA website. So as a summary, here's the next question for you. What aspects must be considered when building a query? And here more than one answer may be correct. What aspects must be considered when building a query? Think about the principles that we have just discussed. Quality of source data, internal MedDRA version update processes, MedDRA structure, organization-specific coding conventions, and data characteristics. What needs to be considered? Again, let's see where you're exactly. All aspects need to be considered. Well done. All aspects as we just discussed with the principles that we discussed. You will have to really think about when building a query about all these aspects in order to make sure that your query is complete, that you do not miss cases, but also that you are not too broad so that your retrieval reveals too many irrelevant cases. Any questions, Leanna, before starting with the next topic?
Currently no questions, thank you, Carol-Ann.
Oh, we have quite a silent audience today. Please raise questions. Yeah, be sure that if you consider a question, others will have the same question as well. Hopefully everything is clear. If not, raise your hand, ask questions. So the PTC, after these principles, the PTC then addresses general search strategies that should be applied when investigating the safety profile of a given medicinal product, how to present the data, and also the impact of these methodologies for data analysis. At first, you would usually start with a complete general overview on your safety data. The standard data presentation should be by primary SOC, displaying the PTs with their primary SOC hierarchy. This will highlight the distribution of adverse reactions, adverse events, with the advantage that each PT will only be represented once and that there will be no duplicates. And your data will be presented in a way that allows for the recognition of patterns and identification of areas for more in-depth analysis. When using this primary SOC approach for your tabulations, it is important to know that there is an internationally agreed order of system organ classes for the AE presentation. And this internationally agreed order is, for instance, required by the European Summary of Product Characteristics Guideline. The internationally agreed order can be found in the MedDRA Introductory Guide in the appendix. And this agreement, you may ask yourself, why is this at all necessary? Well, it became necessary due to the MedDRA translations, because SOC presentation in alphabetical order would look different depending on the different MedDRA translations. This was again done for standardization purposes. In this instance, standardization of safety data presentation. And the agreed order of SOCs is based on medical relevance, starting with SOCs like infections, neoplasms, and blood, and ending with SOCs like social circumstances and product issues. A primary SOC overview may be the only form of data display necessary for a small data set. In terms of data display, you may not only use tabulations, but also line listings for small data sets. But for larger data sets, consider the use of grouping terms like HLTs and HLGTs to aggregate related PTs. We saw an example before with our investigational terms. You may also use a graphical display for larger data sets to make your output more comprehensible. However, the limitation of the primary SOC approach can be that we get incomplete groupings due to primary SOC allocation rules because medically related events are distributed across many system organ classes, as mentioned with the example of the hepatic disorders before. And also the output by primary SOC may be quite lengthy, especially when creating line listings. So this is now an example using a nice graphical display per primary SOC allocation for a larger data set. And when looking at the relative frequencies per SOC, one could suspect that there is a problem with this product related to psychiatric disorders, nervous system disorders, gastrointestinal disorders, and some general conditions. So these may be the system organ classes that one might want to focus on. Here, a different and nice way of data presentation that regulators like to see as well. The data are listed per primary SOC, HLT, HLT, and PT with the event counts at the SOC and PT level. If you have identified specific areas of interest in your cumulative data output that you would like to investigate in more depth, you'll start using more focused searches. Scenarios would be further examination of clusters seen in primary SOC output or previously identified safety concerns like known class effects, results from toxicology and animal studies, monitoring events of special interest, or responding to regulatory queries. One option would be to use secondary SOC assignments for data output and presentation. But again, some programming will be required if the database does not allow for an automated output per secondary SOC. However, it will have the benefit to provide a more comprehensive view of medically related events. But be careful, because the same event may be counted several times when doing aggregated data analysis because of the multi-axiality of MedDRA. You may also use grouping terms for smaller data sets. And if dealing with large data sets, consider the use of the standardized MedDRA queries for your focus search. And if there is no suitable SMQ for your specific question, use a customized search by either modifying an existing SMQ or by building your own ad hoc query. As mentioned before, the SMQs and modified SMQs are out of scope of our webinar today, but you can hear more about them in a separate webinar on Tuesday next week, if you like. I have just mentioned that focus searches that are based on secondary SOC linkages of terms will provide you with a more comprehensive view of medically related events. Now let me illustrate this with an example. Let's assume that you would like to know the incidence of autoimmune disorders with a specific drug. You get a list of 23 PTs per primary SOC for a total of 49 patients. Here you have the patient numbers. That is shown on the next 3 slides. Now you would review the cases and maybe refer to medical textbooks to find out whether the condition, like, for instance, Evans syndrome, may have an autoimmune etiology. In other instances, autoimmune etiology is clear based on the PT name, like here, autoimmune neutropenia. Next one, what about birdshot chorioretinopathy? May this have an autoimmune etiology? Again, autoimmune uveitis is clear. Primary biliary cholangitis, we heard that this may have an autoimmune etiology. So, and also here we have the information autoimmune in the term name. Here we have one PT that really resides in SOC immune system disorders. It's autoimmune disorder, does not contain any information about the affected site. That's why it's only grouped under immune system disorders. But here, what about SOC musculoskeletal? Here we have, well, arthritis, muscular weakness, not really relevant for autoimmune disorders, but polymyalgia rheumatica or rheumatoid arthritis, yes, of course. But again, vitiligo, may this have an autoimmune etiology? So you would spend time for further clarification of the background of these conditions. Now, how can I explore primary and secondary linkages of PTs in the MSSO MedDRA browsers? So let's look at the features of the MedDRA browsers. Out of the 3 MedDRA browsers that are provided by the MSSO, one is intended to be installed on local computers. It's the MedDRA desktop browser. It can be downloaded from the MedDRA website together with the release files, and it makes you independent from internet access. The 2 other browsers, the MedDRA web-based browser and the mobile MedDRA browser, they are of course you are dependent on internet access. But all 3 browsers require a MedDRA ID and a password in order to access them. They allow you to view and search MedDRA and the SMQs. They support all MedDRA languages. They have a language-specific interface, and then they have a so-called research bin feature, and that I will demonstrate later on. Very helpful for building queries on your own, ad hoc queries. Both the desktop browser and the web-based browser can nicely support your data retrieval and analysis tasks. They have additional built-in functions that allow you to view primary and secondary linkages of MedDRA terms and include a functionality that is called hierarchy analysis. This slide displays the primary SOCs of the 23 PTs that you saw before, and it is obvious that they are linked to a number of SOCs based on their manifestation site, but only one is linked to immune system disorders, the PT autoimmune disorder. So it would be helpful to get a display of all these 23 PTs using their secondary SOC linkages, because we would expect that those conditions that have an autoimmune etiology would have a secondary linkage to SOC immune system disorders. This would be of a much more efficient analytical approach. Most users may not have the ability to look at the MedDRA hierarchy of a group of terms per secondary SOC allocations, but with recent updates to the MSSO MedDRA browsers, this is now possible. Now, how can the browsers help us to find out secondary SOC linkages for a given MedDRA term? Here's the best options. There are other options that you can also use, but this one is really straightforward. With the more advanced features of the MSSO MedDRA browsers, you will be able to get this done really quickly. You would open the MedDRA browser and click the tab Hierarchy Analysis, and then upload your data set. So let me show you how to do that. Here we are with the website again. And now I would like to open the web-based browser. Here's a shortcut. I need my MedDRA ID and password in order to log in. And here we are. And on the top side here, on the right-hand side, you see the tab Hierarchy Analysis. So if I click on it, this window opens, and my data that I have, that we just saw, they are coded in version 27.0. So I will have to select the version in order to match the version of my data with the version of that I use for my data presentation. Then I click Next, and I will have to select the file. And here we are. I have this spreadsheet, this SMQ analysis exercise. Here it is. I select it. I have selected it and say Next. And here we have the output already. So we have it here, MedDRA English version version 27.0 with the secondary SOC assignments. We see the date where these data were extracted, when they were used. And let me now filter this and sort it in alphabetical order. Oops, what happened? Didn't work. Didn't work for any reasons. The autoimmune, very strange. I tried it before and it did work. Let me take a different approach and select the autoimmune disorders. I think I made a mistake when extracting this because we only see, we don't see the secondary linkages, but it says yes. Let me close this and do it again. Here we are. Yeah, I have many more now here. Here we are. And now let me and I will just take the ones that are grouped in SOC autoimmune disorders. This is an HLGT, and here we are. So here we have our PTs that have a secondary SOC linkage to immune system disorders, HLGT autoimmune disorders, and we are looking for autoimmune disorders. And you see that, of course, our one of these PTs, namely the autoimmune disorder PT, has a primary linkage to immune system disorders. All others only have a secondary SOC linkage to immune system disorders. And you see them here. Autoimmune neutropenia, clear. Evans syndrome obviously may have an autoimmune etiology. Same is true for birdshot chorioretinopathy. And also primary biliary cholangitis, we suspected this already, polymyalgia rheumatica, rheumatoid arthritis, but also vitiligo. So this way you have a very nice feature how you can analyze your data based on secondary SOC linkages by importing your data set and then extracting the data with secondary SOC linkages and filtering your spreadsheet. Didn't work at first, I don't know why, but now I could show you. Now let me go back to my slides. So this is how the spreadsheet looked like. So here you have the 23 PTs that we were looking at. This is how the spreadsheet that you import into the tool, into the browser, should look like. And this is what I wanted to show you. It didn't work in my instance, so I wanted to filter or have an alphabetical order of the HLGTs and show you all PTs that are grouped under autoimmune disorders of our data set. So I had to do it differently, but this is what you can do. I just filtered for autoimmune disorders at the end. And returning to the original slides from this exercise, we can now have a different view on our data using the secondary SOC allocation and HLGT autoimmune disorders to demonstrate that our data set contained 30 possible cases of autoimmune disorders out of a data set for 49 patients. So, and you see the PTs representing autoimmune disorders here. Any questions, Leander, related to this feature and the browsers?
Oh, no questions, Caroline.
So hopefully it was all clear, although it didn't work at first. And yeah, now let us talk about how to develop a query using MedDRA in more detail. So which level of the MedDRA hierarchy is normally used for building a query? What do you think? LLT, PT, HLT, HLGT? What level is used for compiling a query? When you look, PT, yes. PT, exactly. So it's the PT level that is used when you compile a query. Fully clear, well done. Thank you for participating here. It's the PT level. Now let me illustrate this, and I will use this graph for it. If we will start from the left-hand side, you see that we start out with a clinical trial or drug safety database, and these databases contain cases with events coded to MedDRA LLTs. So we could have a list of LLTs assigned to reported adverse events for each particular patient, taking a particular or using a particular medicinal product. Now let's look at the right-hand side. A query is built on the PT level, and it may be a standardized MedDRA query, an SMQ, or a query we have built. Ultimately, a query is a list of PTs we think represent the condition of interest. And because the cases in our database are coded to LLTs, the PTs of our query also get broken down to LLTs. And when running the query, a matching process takes place, looking for a hit or match between the LLTs of our list contained in our query and the LLTs used for coding the cases. And if a match is found, that case will be retrieved. And in this way, a list of potentially relevant cases will be created for further medical assessment. There are some important principles that have to be taken into account when building a query. First of all, very important, before starting building your query, you really cannot spend too much time for defining your condition of interest. You need to have a clear understanding what you are looking for based on good and reliable references. And based on the definition, you will then have to develop inclusion and exclusion criteria to define what kind of cases you would like to identify and what type of cases you would not like to see. So if your drug is used in adults only, you would not be interested in including PTs that represent, for instance, neonatal forms of your condition of interest. Only then, only after you have done all this pre-work, very important, you will start to search and identify relevant PTs that represent the condition of interest. And for doing so, you need a good browser. Always consider the 3 non-multi-axial SOCs and other support SOCs like, for instance, General SOC or SOC injuries when doing your searches. Make sure to look at the neighbors of selected PTs, especially those with a secondary SOC linkage, because there may be additional and even more specific terms available that are of interest for your query. Use grouping terms and the underlying PTs where appropriate, as we saw with our example with the cardiac arrhythmias, and avoid using LLTs because they are very granular and there's a lot of duplication on that level. The LLTs are more a guidance for coders and contain a lot of duplication and because in order to support autocoding. There may be exceptions to this rule, like in the instance of combination products, like for example hormone-releasing intrauterine systems. IOD LLTs, like IOD dislocation, are only represented on LLT level, grouped under a more general PT device dislocation. So in order to not produce too much noise with your retrieval, to not retrieve too many irrelevant cases, you may want to exclude terms for the dislocation of all other types of devices like catheters or cannulas, intraocular lenses, joint prostheses, etc., that are also grouped under PT device dislocation and therefore only include the LLTs for the IODs. When done, you should store your query for future use and make sure to review the impact of new MedDRA versions on its content and adapt the PT content of the query as necessary. So these are the important principles of how a query should be built and maintained. We will now apply these principles and build a query to identify cases with cardiac arrhythmias. So what is the first thing to do? As you saw, it is the definition of the condition, arrhythmia, and the specification of the in- and exclusion criteria. And after doing so, what would be the first SOC you would look into? Well, based on the manifestation side, it would be SOC cardiac disorders. And there you would find a nice HLGT called cardiac arrhythmias. We already addressed this HLGT earlier when talking about the MedDRA hierarchy. Would I now just take all these PTs that are grouped under this HLGT and say, okay, fine, I'm done? Well, why not? You heard that we will have to look into the non-multi-axial system organ classes as well and other support SOCs. So let's see. In SOC investigations, you would find the HLT ECG investigations with relevant terms and also the HLT heart rate and pulse investigations. There you would find termed PTs like heart rate irregular, and these are all relevant for your search, for your query. And if not looking into SOC surgical and medical procedures, you would miss relevant terms like the PT implantable defibrillator insertion under the HLT cardiac device therapeutic procedures and the PT cardioversion under the HLT cardiac therapeutic procedures. And you would, of course, also have to explore the third non-multi-axial system organ class, social circumstances, for relevant terms, like, for example, PT cardiac assistance device user. And what is if the arrhythmia causes collateral damage? A patient may suffer atrial fibrillation, for instance, develop an embolus, and suffer embolic stroke. So you may want to include neurological signs and symptoms related to stroke. Or suppose that there was a ventricular arrhythmia leading to cardiac syncope. Then you may want to add some PTs from HLT disturbance of consciousness, NEC. And there are a number of other areas that might be relevant for your query, like terms under HLT dyspnea, because shortness of breath may be the main symptom of the arrhythmia. And if you wouldn't have looked into the supportive system organ classes like the SOC general, you would have missed the PTs cardiac death and sudden cardiac death. And these, of course, are also relevant for your search when searching for cardiac arrhythmias. The next slide demonstrates how important it is to have a comprehensive search strategy when looking for relevant PTs to identify potential cases of interest for the condition arrhythmia. You see a list of adverse events for 10 patients. Here are the adverse events, where first superficial medical review came to the conclusion that 7 of them are potential cases of cardiac arrhythmia and that additional 3 are unlikely to be cases of cardiac arrhythmia. Now let's have a look at these 3 first. Unlikely, patient ID number 1, nausea, vomiting. Yes, understood. Breast cancer, postmenopause, another patient. And here we have a cerebrovascular accident, could of course be related to a cardiac arrhythmia like atrial fibrillation, but here we have the additional information, prostate cancer, so most probably this is a thrombotic cerebrovascular accident related to the disease of the patient, the prostate cancer. Now let's look at the potential cases. The first suffered sudden death. The second had an ECG that was normal, suffered dyspnea, and suffered cardiorespiratory arrest. Here we have a syncope and palpitation, pacemaker-generated arrhythmia in this patient, atrial fibrillation, cardioconversion in this patient, long QT syndrome congenital here in this patient, and cardiac assistance device user in this patient. Now, let's check in how many instances these events in these potential cases did not have the primary SOC cardiac. So sudden death was in the general disorders and administration site conditions system organ class. ECG abnormal in investigations, dyspnea in respiratory. Cardiorespiratory arrest, of course, in cardiac disorders. Syncope can be found in nervous system disorders. Again, palpitations in cardiac disorders. Oops. Pacemaker-generated arrhythmia in general disorders again. Atrial fibrillation in cardiac disorders, but cardioversion in surgical and medical procedures. Long QT syndrome congenital, primary SOC is congenital, of course, and cardiac assistance device user, you will find this PT in social circumstances. So this is what goes wrong if you only focus on a particular SOC and don't look at other SOCs when building a query. You will miss relevant PTs, and because of that, you will miss potential cases of interest with your retrieval approach. Let us now build a query from scratch for the topic ototoxicity, meaning a toxic effect of a drug on the inner ear or auditory nerve that is characterized by cochlear and vestibular dysfunction. And we will be using one very useful feature of the MedDRA browser that I've mentioned before already when introducing these browsers, that is called Research Bin. We will consider diagnosis terms, signs and symptoms, investigations, surgical medical procedures, social circumstances, of course. Now let me switch to the browser again. Here we are, and start with building our query. So to build a query for the identification of potential cases of ototoxicity, you would first explore, of course, the SOC representing the manifestation site, that is SOC ear and labyrinth disorders. Here we are. So we would do a top-down search. Here we have the HLGT hearing disorders. This looks very promising. And here we have the hearing losses. And then you start looking into the PT content of this HLT. Which of these PTs are relevant for my search for ototoxicity? So it's not a conductive deafness, but I would select the deafness terms. It's a general term, but some of these ototoxic events may just have been reported as deafness. So let us look into it. Right mouse click, add to research bin. And if I click on it, you see that my research bin opens and I see this PT that I have selected in my research bin. Let us define our topic. It's ototoxicity. And we do not want to see the secondary SOCs. We just want to have a list of PTs to give to our programmer to run this query that we want to build. Next one, deafness bilateral. Yes. So here we are, add to research bin. Deafness congenital now depends on your in and exclusion criteria. If you are looking for adults only because your drug is only used for adults, then this one would not be relevant. Otherwise you would add it. Deafness neurosensory, very specific. Yes, of course, this needs to be added to my research bin. Deafness occupational has a completely different etiology. But deafness permanent, add to research bin. Transitory as well, add to research bin. Traumatic, different etiology. Deafness unilateral, yes, add to research bin. Sometimes it may only be a unilateral manifestation. And you see some color coding here. The green ones have only a secondary linkage to this HLT. These highlighted in green here, there's the green square around the PT. So this is because these are congenital syndromes that have their primary linkage to the congenital SOC. Of course, these are not in our focus. We want to have drug-related events. So all of these congenital terms are not relevant for our search. Hypoacusis, of course, needs to be added. Add to research bin. Mixed deafness, maybe, because it also mixed means that not only the middle ear, but also the inner ear is affected. Add to research bin. Mum's deafness, different etiology. Neonatal, again, depends on your in and exclusion criteria. Neurosensory, yes, we need that. Sudden hearing loss, of course, add. And this is how you can build your query here. Hyperacusia, let's look at the other HLTs, is not relevant. Hearing disorders, NEC, let's see. Auditory disorder is really very general, so I would not include this one. This would really reveal too many irrelevant cases. And let's look at an NEC term, oral disorders NEC. I mentioned that sometimes you will find terms in these NEC groupings that may be relevant for your specific question. Let's look into it. Ear congestion, discomfort, dryness, infection, inflammation, neoplasm, odor, pain, pruritus, swelling, no. But here, ototoxicity, this is exactly what we are looking for. So this PT, of course, needs to be added to our research bin. Here we are. So here we have this, we have explored inner ear and 8 cranial nerve disorders. Inner ear disorders, what do we have? Acute vestibular syndrome, add to research bin. Inner ear disorder, quite general, but at least specifies it's inner ear disorder, add to research bin. Otolithias, these are all vestibular disorder, yes, add to research bin. That's it. Inner ear infections, inflammations, inner ear signs and symptoms. Remember, ototoxicity can lead to certain signs and symptoms. Maybe only the signs and symptoms are reported, like nystagmus, for instance. Add to research bin. Tinnitus. Add to research bin. Vertigo. Add to research bin. Add to research bin. Vertigo labyrinthine. Vertigo positional. Add to research bin. Ataxia. Add to research bin. And vestibular nystagmus. Add to research bin. So these are just demonstration. You would also look for the 8th cranial nerve disorders. So the neuroma is not relevant, but maybe the 8th nerve injury would be a relevant term. Add to research bin. So this is our manifestation site. We have covered the manifestation site. Now let's look into the non-multi-axial SOCs. Investigations. Here we have the neurological special senses and psychiatric investigations, auditory and vestibular diagnostic procedures. And here we have the audiogram abnormal, add to research bin, electrocochleogram abnormal, add to research bin. What else? Rinne tuning fork test abnormal, add to research bin. Vestibular function test, Weber function test. So that's it. What else? Other non-multi-axial SOCs. Remember social circumstances. Here we are. Let's open social circumstances. And under lifestyle issues, you find the HLT disability issues. Lots of terms in here, and among those we have hearing aid user, add to research bin, and hearing disability, add to research bin. All others are related to other devices or prostheses to overcome disability. And now surgical and medical procedures. You will find those under head and neck therapeutic procedures, ear, nose, and throat radiotherapies. No, external ear is not of interest for us, but the inner ear therapeutic procedures. And here we have the cochlear implant, add to research bin, the labyrinthectomy, add to research bin, and vestibular apparatus operation, add to research bin. So this is how you would build a query. And as I told you, it's really important to have a clear understanding of the condition you are looking at, what you would look for in order to really be able to search the complete MedDRA hierarchy for the terms that represent the condition of interest. And it's really a very broad approach that you have to take there, not only considering diagnosis, but also the signs and symptoms of the condition, investigational tests that are performed in order to diagnose the condition, surgical procedures, medical procedures that are performed in order to treat the condition of interest, and also social circumstances that may be related to your condition of interest. All of this needs to be considered. And you see that we have quite a list of terms here for our condition. We don't want to export the secondary SOC. You can now say that we want the ototoxicity. Here we are. We want to export our list of PTs. Here we have it. And you see that you have our title, ototoxicity, the topic we are looking for. We have the MedDRA version 27.1 that is documented so that we know which version was used to compile this query. And you have all your all the PTs that we have considered But of course, this is not at all perfect. Our query, you would need to consider definitely more terms, and for searching for ototoxicity. So this was just a demonstration. So if you don't export your query, if you close the browser before exporting it, you will lose everything. So when closing the browser without having exported your search results, they will get lost. Don't do that. Always export them. And if you are not done with your search yet, what you can do is to really go back to your, let me go back to the browser here. You can go back to the browser. You can say, show my research bin. Let me close it. Let's assume that we have, and open it again, show my research bin. Oh, I have to close the browser, log out. And then I will log in again, because otherwise it will always show me all the PTs that we have already compiled for our, or listed for our search. And if I now say show my research bin, it will be empty, and I could now import my file that I've stored in on my local computer in order to continue my work. Just to let you know. So this was just a demonstration, as I said, to show you how the research bin function works, a very helpful feature of the browser for building query. As a summary, let us go through 2 additional poll questions. So what is the first thing to do when building a query? What do you think? What is the first thing to do when building a query? Opening the MedDRA browser and selecting relevant PTs, opening the browser and selecting the relevant LLTs, get a clear understanding of the medical condition of interest, and or defining in- and exclusion criteria. What do you think? What is the first thing to do when building a query? Very important to remember, because otherwise you will start working on your query over and over again. Exactly. Get a clear understanding of the medical condition of interest. That's the first thing that you have to do before defining in- and exclusion criteria and before opening the MedDRA browser and selecting relevant PTs. So that's the first thing to do, to get a clear understanding of the medical condition of interest. Well done. And PTs that are included in a query, either a customized query, an ad hoc query, or an SMQ, a standardized MedDRA query. What are the PTs that are included in a query? What do they relate to? Lab tests, diagnosis, toxicologic issues, clinical syndromes, symptoms, histopathology findings, physical findings, medical surgical procedures, family history, medical social history, clinical science, terms that relate to fatal outcomes, diagnostic and procedure findings. Exactly. All of them have to be included, need to be considered. So it's always, if you build a query, you really have to search the full MedDRA hierarchy and consider also the non-multi-axial SOCs. I've mentioned it before. 3 non-multi-axial SOCs, investigations, surgical and medical procedures, social circumstances always have to be considered. Not only the SOC representing the manifestation side of the condition. And sometimes also support SOCs like pregnancy, for instance, if the condition of interest relates to pregnancy, or the general SOC, as I've shown earlier, because fatal outcomes like cardiac death or acute cardiac death, sudden cardiac death, are grouped in general SOC. Well done. All of them need to be considered, are included in a query. So I hope you found these examples and exercises and demonstrations useful. We could see that MedDRA is a powerful tool for data retrieval, but it requires, first of all, solid medical knowledge about the condition of interest, as well as a solid MedDRA knowledge in order to identify the relevant PTs. The size and granularity of MedDRA makes the terminology much more useful as compared to the lack of specificity of legacy terminology. But this benefit on the coding end may require a more creative approach to retrieve the coded data. You could see that query building needs really time and resources, and therefore it is really well worth the effort to share the query with your colleagues, to store it, and to maintain it for future use. Now I will stop here to ask if we have last-minute questions, maybe. Leander?
Yes, we have a question, Caroline, thank you. Is the SMQ queries part of signal detection process?
Yes, usually yes. So it depends on the size of your database. So I can say for the regulators, they are using SMQs on a regular basis in order to search their databases as a routine measure. And also for larger databases, the use of the SMQs is a normal procedure. So for signal detection, because with the SMQs you really cover a lot of topics that are of relevance for the safety of medicinal products.
Thank you, Caroline. And there's no other questions, but I did add in the temporary password for the MedDRA browser, the training password that we have, in case we had any attendees who were joining us and they're not aware of their credentials. So that's in the chat if anyone wants to access and practice what you were demonstrating, then that's in the chat. Perfect. Thank you, Leander.
So then let me continue with some additional information that may be of relevance for you. So first of all, a summary of what we have covered today. So we have discussed topics that are addressed in the MedDRA data retrieval and presentation points to consider document. We have discussed the applications of MedDRA in data retrieval, presentation and analysis. And we also looked into the use of MedDRA for developing queries with a demonstration of the research bin functionality of the MedDRA browser. If you would like to have more information about MedDRA topics, I can only highly recommend to refer to the MedDRA website. You'll find a lot of useful information there. I've demonstrated some of them. In addition, you can always contact the MSSO help desk with your questions, and you can be sure to get a very quick and useful response from the colleagues there. Also, you will find a frequently asked questions FAQ section on the website where you may find answers to your own questions. And here again, the links to the 3 browsers that the MSSO provides for free to the MedDRA users. Additional links to the WebCR tool to submit change requests, just in case you consider a change request. A link to the training schedule, where you find information about the trainings, webinars, and also face-to-face trainings that are scheduled for the next 2 or 3 months. And the link to the MedDRA support documentation. I've shown you where to find it on the website. Under support documentation, you will find the points to consider documents, the companion documents, but also some per version, some of the documents like the MedDRA introductory guide and also the SMQ introductory guide if you are interested in the SMQs. You can not only contact the MSSO via our help desk, but also via other communication channels, as you can see when clicking on the button Contact here on the right upper side of our website. You'll find us on Facebook, on LinkedIn, on X, and also on YouTube. And you can also join English, Spanish, French, Indian, Russian, Arabic WhatsApp groups and a Chinese WeChat group. And we also offer an online contact form where you can directly type in your questions and submit them. And last but not least, you can also have an instant discussion with our colleagues from the help desk through a live chat that you can call up from the website. So the YouTube channel may be of special interest for you because there on this YouTube channel, you'll find recorded sessions of our training events sorted by trainers. So let me shortly show you how this looks like. Where am I? Here. So here we have the training materials. Here's this tab Contact. Here I click on it. And if I click on this icon, YouTube, it will bring me to the MedDRA MSSO, the MedDRA YouTube channel. And here you see the playlists for all trainers that we have. So you see that some of the trainings are provided in Portuguese, some of them are provided in Chinese or in Spanish, in Korean, in Russian. Where are the Russian ones? Here by our colleague Jelena. So a number of languages that are used in our training. So if English is not your mother language, it may be useful for you to watch one of these recorded sessions. And sometimes it's also nice to really either revisit a recorded session that you have attended in order to memorize some of the topics that were addressed there, or also to watch a recorded session of another trainer, because everybody has a different style of presenting. So that may be very useful for you. So if you want to really look into what we have addressed today, you see that there, if you click on the icon representing my usual, the standard training material, you see that the data analysis and query building with MedDRA is in there from the last session, so it will be replaced by this session by Friday. So if you want to revisit some content, you can do so by visiting this YouTube channel. This is what I wanted to show you because I find this very helpful for training purposes. Now, with this, we have now come to the end of this webinar, and I hope that you have found this session interesting and also useful, and hope to meet you again in one of the webinars that we are offering on a regular basis, or in a face-to-face training event. And with this, I would like to thank you for joining today, and also thank you to you, Leander, for supporting me today. And enjoy the rest of your day wherever you are. Take care. Bye-bye.
Thanks, everyone, very much. Appreciate it. Thanks then. Bye-bye.